Good afternoon. Thank you for the invitation. So today we will discuss about how to monitor a thyroid cancers after the surgery and long-term monitoring of that. And I am basing my talk based on the recent guidelines, and which has been we were following most of the things. There is not major changes. Some of the changes in the guidelines, I will highlight why those changes have been made. So as you know, from morning, most of the um, speakers have already mentioned that differentiated thyroid cancers, they have excellent disease specific survival rates, 98, more than 98%. And recurrences do happen, and that usually happens in the first decade, maybe late recurrences also seen. So we have long time being following a risk adapted follow up. Certain patients who are prone to have more recurrences, they are followed more intensively, and some patients who are not are that. So that is the risk stratification has been came into practice. So the aim of surveillance is to detect any actionable disease as soon as possible, and also you avoid over testing. So this is what evaluation, the risk adapted follow. So initially, as in many of the cancers like thyroid cancer also, it was a static way of predicting the risk. The first step, you identify the disease, the patient have a risk assessment based on different parameters, and that is a static method of detection. Now these thyroid patients, they live longer, 20 years, 25 years, long term. So and some of them, they develop recurrences. So we could study these cases in detail. So that is why the concept of dynamic risk stratification came. So if you see in the 88 2009, they mentioned about the risk of recurrence, and 88 2015 they introduced the concept of dynamic risk stratification, and 2025 they have divided the risk stratification to 4 tiers: low, low, intermediate, intermediate, high, and high. So it became a little bit complicated in the sense of how to risk stratify. So it will the aim is to more precisely classify the cases, so that some of the patients can be more intensively followed up while others can be taken out from the intensive surveillance program. So this is the ATA, the AJCC, and you see the T34, T3B and T4Bs, and T4 and N1Bs and M1s. They form the high risk category of the patient. So advanced big thyroid, extracapsular, big extracapsular nodes involving the larger size nodes involving the lateral compartment, and metastatic disease. Basically the overall that gives the high risk category of these patients. So the risk of structural recurrence from high risk, intermediate, high, intermediate, low, low risk. So as you see, I already mentioned advanced big thyroid, they have risk of higher risk of recurrences, nodes more than 3 centimeter higher risk of recurrences. Intermediate high is lateral lymph nodes, which are also present, but they are less than 3 centimeters. And intermediate low is lymph nodes are there, but they are in the central compartment and maybe more than 5 lymph nodes. And when they are less than 5 lymph nodes, they to come in the low risk. The similar for the follicular thyroid cancer, but it is based on the invasive nature. The highly invasive vessel angio invasive follicular thyroid cancers, they have a high risk of cancer. They are high risk category. So this is the risk of recurrences, which is you see uniform for the low risk and high risk categories for follicular and differentiated thyroid cancers. Low risk categories as less than 10%, intermediate is 10 to 15, 16 to 30, and high risk have 30% of risk of recurrences in the follow-up period. So assessment of so initial risk assessment, it detects the type of intervention we are planning, whether it is total thyroidectomy, lobectomy, or a central compartment clearance, and radioiodine ablation. All those things are dependent on the initial risk assessment. So start with that. Then the initial follow-up period, we looks into whether there is a patient need RAI or other things, and then if the otherwise they go for a restratification at 6 to 12 months, and that is called a, so assessment of risk assessment should be done at every follow-up. Risk of recurrences should be noted. So after follow-up we consider it as response to treatment. So initially risk of recurrences and then response to treatment. Basically it is risk of recurrences or residual disease or something, but that is the dynamic response assessment. So dynamic response assessment is a process that continually adjust patients' risk level by monitoring their response to treatment. So it could be real time, and gives us a more individualized approach. It also have an independent predictor for outcomes, and it also informs regarding the managing decisions. Should be used in conjunction with the initial ATA risk of recurrence estimates. So morning, Dr. Dabakar has already mentioned about the data framework. That is the newly introduced in the 2025, which is diagnosis, assessment and treatment and dynamic assessment phase. So the initial risk, initially we go for the various diagnosis, the risk benefit assessment, treatment decisions and response assessment. So it's a continuous process, but then the dynamic assessment phase is performed during the response assessment phase. Best assessment usually should be done within the 3 months after surgery to guide whether it is needed RAI use or individualize the dosage. So I think the speakers following will enlighten this aspect in detail. But what is the dynamic categories? We have excellent response, indeterminate response, biochemical incomplete response, and structural incomplete response. Excellent response means they are biochemically and structurally they are free of disease. After 6 months we are assessing the patient, there is no evidence of any residual disease in the neck or in the thyroid bed, and biochemically they are clean. If there is some doubtful disease persistent in nodes or sometimes especially nodes in the lateral compartment or central compartment, which FNAC is not correlating, we call it as indeterminate response. And when there is a TG rising TG level or antibodies, TG antibodies, then it is a incomplete, biochemical incomplete, without any structural evidence of any structural disease, persisting disease. And structural disease is basically usually follow after R1 or R2 resection, so you have already left behind some disease, so they are always have a higher risk of metastasis. So biochemical incomplete response post total thyroidectomy or neck dissection with RA ablation. And here the non-stimulated or stimulated TG level. Stimulated, if it is a stimulated TG level, you look for a more than 10 nanograms per ml. That is the thyroglobulin level estimation. And increasing levels of thyroid TG antibodies are also a cause of concern and may be indicating of a recurrent disease or residual disease. So serum thyroglobulin measurement after thyroid surgery, usually the first we do it around 6 to 12 weeks after surgery. So the patient comes with the histopathology report and everything. Before 6 to 12 weeks, during that follow-up period we do the TG, and always it should be complemented with a measurement of TG antibodies also. So this results at that level dictates further management. And in case of lobectomy, we do one time TG level, and after that possibly we will continue, will not repeat the TG, because lobectomy, the indication or recurrence prediction of TG level predicting recurrences is not, there is no clear cut data. So in case of lobectomy, only one time do it, so that will serve as a baseline level. So what are the imaging modalities? Of course, before radio, suppose the patient is being decided for a radioiodine treatment, it's better to have an ultrasound before that, and also TG antibody postoperatively. Otherwise, if patient does not go, 6 to 12 months, cervical ultrasound, evaluate the thyroid bed and central and lateral lymph node compartments. FNAC for suspicious lymph nodes. In that case, there are ultrasound shows suspicious 1 centimeter lymph node, you should do FNACs, and in case patients who receive RA, always it is followed by a post-therapy whole body scan, which can document the response to the treatment. I think, yeah. So this is the long-term management for low-risk cancers, dynamic risk assessment, TSH management, then the after total thyroidectomy with or without RI, serum TG should be measured 6 to 12 months, and for patients with circulating TG antibody, an ultrasound can be done. So every so initially 6 to 12 months, and then every 1 to 3 years. That is the current guideline says of follow-up, especially when the patient is showing ultrasound is negative and maybe the TG levels are normal in the assessment. But if it is sustained excellent response after 5 to 8 years, routine ultrasound can be discontinued. This is one new guideline proposal in this thing. Previously, ultrasound and TG is continually do it. So they say about 8 years with excellent response, you can discontinue the excellent ultrasound. And in case of high risk cases, it should be continued every 3 to 6 months. The 3 to 6 months, sometimes you do 6 months, sometimes you see 3 months, depends upon how much the risk estimation by the treating physician. Suppose I have diseases there, or I'm thinking of nodes or something, then we may reduce the duration of that. But otherwise, usually 3 to 6 months. And then, so ultrasound, then annually we can do it. If there is a rising TG, and if ultrasound is not showing much, then you can do a diagnostic RAI. CT MRI also when TG rises and US is negative or equivocal. And in case of TG positive, iodine negative disease, you can do a FDG PET. So FDG RA is basically when there is suspicion of recurrence, abnormal initial post-therapy scan, or high suspicion due to large remnant disease, and when there is elevated TG antibody. For low risk, low intermediate, or patient with excellent response, it is not routinely recommended. And when there is no prior RAI treatment, there is no need of doing a whole body scan. And excellent response post ablation and initial post therapy WS shows no uptake, and again there is no need of repeating the WBS every annually or something. Only when there are specific indications we should do it. So FDG PET, again I already mentioned, where is rising in the TG level, and there are high risk DTC when standard radioactive scans are negative. So there is a talk on tennis syndrome, so they will elaborate more, but TG levels are generally greater than 10 nanograms per ml, and RA imaging is negative. So there is rare radioiodine refractory data for. So how will you determine the radioiodine in this particular situation? Is that radioiodine negative TG elevated? In this such situation, FDG PET will be useful to categorize such tumors. So these are indications where you need to do FDG. Routine post-operative FDG PET is not recommended. So that is another important aspect. I will finish in two slides. ATA 2025, de-escalation and discontinuation of the monitoring. So in very excellent low risk cases, after 8 years, only the ultrasound is stopped, and only the TG level is more. And there is a term called complete remission. That is, if the patient is remaining low risk, excellent response radiologically, and after 15 years they call it as complete remission, and lifelong follow-up only is recommended for high risk patients. So after 15 years you can stop radiological as well as this thing for low risk patients. That is a new recommendation. Of course, these guidelines are based on some of the evidences are not based on very strong details. So I think this will evolve, but we always do like that. And in large long term 15 years, we may not keep them under risk follow up for long. So in conclusion, risk adaptive dynamic follow-up, re-stratify every 6 to 12 months. That is important. We've been doing this. It is being emphasized in the current guidelines too. And antibody trends have to be followed. Rising values, do imaging. Ultrasound is the most valuable image. Frequency reduces after 2 years, and if there is good response 1.5 to 2 years, we can do it. Frequency can be reduced, and stop routine ultrasound after 5 to years of sustained remission. Complete remission, the no routine biochemical monitoring after 10 to 15 years. And in case of high risk cases, you should continue with the TG level monitoring even if there is no structural changes. So that is important. And advanced selective cases of PET CT when TG rises. So this, thank you so much.